I am very pleased to be here and really appreciate all the work that went into having this event, as well as to just have an opportunity to congratulate you in person for all the strides that have been made in Illinois. Many states across the country are looking to Illinois as a leader on this fight. I guess I shouldn't have said any of that until I tell you that I'm here as an individual scientist from the intramural program of the NIH, and I do not in any way represent the NIMH, NIH, DHHS, the US federal government. Nor do I tweet at night, but that's just an inside joke. So, yes, now you know. Never mind. Obsessive compulsive disorder, we all think we know from movies, from the TV show Monk, from other things. You may even have had it as a child. 1 in 50 adults do have a history of having had obsessive compulsive disorder. It differs from the typical compulsiveness that got us here on time and makes us actually intelligent, hardworking survivors within the 21st century, in that the thoughts that come into the head are in no way helpful, right? A little compulsiveness is a good trait. Having obsessive compulsive disorder is called a disorder because it interferes with functioning and gets in the person's way. The repetitive, unwanted thoughts and urges and even physical behaviors, which we call compulsions, not only are cause interference, but they are recognized by the person who's suffering from the disorder as crazy. So they know that these thoughts don't make any sense, and that is one way that we distinguish obsessive compulsive symptoms from psychotic symptoms, in which the person loses touch with the irrationality of their symptoms. So try to imagine for a minute that you're having these irrational thoughts, and every time I say the word "the," it's going to trigger a bad thought in your head, and we're going to have to move into a mental ritual that might take you 2 or 3 minutes. It would be really hard to listen to an average talk. Although I haven't said "the," oh, wait, I said it then. I might say it again. And as you can see, when you start talking about this as the doubting disease, then it sets up all kinds of difficulties. Folie à deux, or the doubting disease in French, is one of the prominent features among children who will begin to ask their parents for reassurance about things that make absolutely no sense. It's those 2-year-old why questions that can make you crazy, and you finally just say, why not? Well, in our obsessional children, the why not is not going to stop them. They need to know, am I a good boy? Did I hurt so-and-so by doing such and such? Adult patients have the same thing, but they have the capacity to go back and check. Tics and Tourette syndrome. Tics are just little eye blinks, shoulder shrugs. In the severe cases, the entire body might be ticking and twitching. In the more severe dystonic tics, they take on more of a writhing nature, but they are repetitive in that each time they're performed, they look exactly the same. And that's quite different than what I'll teach you about chorea, which is another adventitious or on top of normal movements disorder. Tourette syndrome is commonly thought of as that triad of tics, OCD, and ADHD, but even in DSM-5, where we worked hard to try and get the definition to be more meaningful, it still is defined by more than a year of motor and vocal tics. So on day 364, you have a chronic or transient tic disorder. On day 366, you have Tourette syndrome. The only difference is time. And that has been problematic for the neurology community, but certainly problematic for other medical disciplines, because Tourette's invokes all kinds of mental images of coprolalia, some of the other more severe symptoms that can go along with that. Within those two categories of obsessive compulsive disorder and tic disorders, we have PANDAS, pediatric autoimmune neuropsychiatric disorder associated with streptococcal infections. And I will take all the blame for having such a silly acronym, because we used to call it anti-neuronal antibody-mediated neuropsychiatric disorder of childhood. You've already seen I work for the federal government. We love our abbreviations, and there wasn't a good abbreviation, and more importantly, I couldn't say it twice in a row without stumbling. So I had a contest among my research assistants. One of them had been to the National Zoo, had seen Ling Ling, And she came back and said, how about PANDAS? And it stuck. Maybe it was the silliness of the name that provoked the controversy. I think it was probably the criteria that we initially published in 1998. And those criteria were based on in-person observations of 125 children in our drug treatment trials at the NIMH, unselected cohort of children with obsessive compulsive disorder, in whom about 1/4 had an abrupt onset of symptoms and they had choreiform movements present. It was also based on a prospective study in which we recruited from the community children with an abrupt onset of obsessive compulsive symptomatology. And what we learned from that cohort was that strep was the most common trigger. Because this research group was actually described in order to find a cohesive and very homogeneous group of children in whom we could sort of parse out the pathophysiology that was leading to their obsessive compulsive symptoms and then apply that to the more general form of OCD, our research criteria require you to have 2 discrete episodes of symptom onset, both of which have been preceded by a group A strep infection. That temporal relationship between the symptom exacerbations and the strep infections in the criteria was left specifically vague because our prototype disorder, Sydenham, Chorea, has a 5 to 9 month lag between the inciting strep infection and the onset of symptoms. Fortunately or unfortunately, fortunately because it makes it easier to make the diagnosis, unfortunately because we didn't know it at the time we wrote the criteria, in PANDAS children that connection is much tighter. And in fact, if you take nothing else away from today, I would beg you that if you are confronted in the nurse's office, as a teacher, as a pediatrician, with a child whose parents say his behavior changed abruptly, do a thorough culture, look for perianal strep. If either of those are positive, treat it. And we don't know what fraction, but we're estimating that as many as 3/4 of children, just with prompt treatment of that asymptomatic strep, will resolve their symptoms completely. So 1 in 50 adults has obsessive compulsive disorder. We estimate that about 1/4 of those are linked to an infectious onset in early childhood. That's a lot of mental illness that could be prevented with a strep test and prompt treatment. There should be absolutely no controversy about that. The fact that it continues, I am not going to try to justify the motivation of the opponents anymore because there is no controversy around perhaps these behavioral abnormalities have been triggered by something. Everybody admits that tics get worse when the child is sick, so why couldn't they also start? And in fact, in a minute, I'll show you that Snelling described that they did start after infections as far back as 1911. But I got ahead of myself, so let's just back up for a minute and say that within this huge group of all childhood onset OCD and tics, and obsessive compulsive disorder is uncommon, right? 1 in 100 adolescents, 1 in 50 adolescents, 1 in 100 children, and we think that PANDAS-related OCD is probably half of the early onset, about 1/4 of all childhood onset, so there you're at 1 in 400. You heard 1 in 200, that would include subclinical cases that don't meet the criteria for full-blown obsessive compulsive disorder, because OCD requires you to have symptoms that interfere for at least an hour a day. But again, this group, relatively small, an uncommon disorder, but tic disorders affect 10% of grade school-age children. And usually they're just simple eye blinks, shoulder shrugs. How many of you work in an elementary school or with, so you know what I'm talking about, right? They're always twitching and ticking. And the parents get all freaked out and they want you to treat this eye blink tic, and you say, no, it'll go away on its own in a few weeks or months, and let's not worry about it unless it's bothering the child. Within that cohort, somewhere between 1/4 and 1/3 of the children will describe an unusually abrupt onset. And literally, the changed child that was fine on Tuesday went to bed, got up the next morning, could not get down the steps because the repeating rituals were so severe, and the obsessional fear that she might take that first step wrong was so severe that the child wet herself at the top of the steps. Or the boy who went to school in the morning, by lunchtime was in the nurse's office crying and just freaking out because the kids in the lunchroom were chewing with their mouths open, the garbage can was overflowing, and the germs were everywhere. And he was completely convinced that he had gotten sick from a contaminant in that lunchroom. By evening, he was actually in the emergency room with frank psychotic symptoms, as well as very profound obsessive compulsive fears, anxiety, panic, and the rest. So 1/4. Within that, it divides into 2 groups, and I told you only had to remember one thing, and that's true. You only have to remember the strep test and treat if positive. But if you can remember 2 things, the other thing that we really need to emphasize is that you do have environmental causes for an abrupt onset of behavioral problems in addition to strep, chickenpox, influenza, and other infectious agents. And that includes psychosocial traumas. So it's very important to do a comprehensive mental status exam, but a comprehensive history in these families, and with good supportive care, really try and get at that history of the possibility of abuse. Sexual abuse can lead to obsessional contamination fears. In our drug study, not in any of the PANDAS studies, we had 2 young girls who had excessive hand washing, but they also had genital scrubbing. And after they got to know us well enough that they could reveal the full history, both had been sexually abused. So you need to keep that in your back of your mind in order to do the best service to your clients or your patients. Metabolic disorders are much less uncommon. In fact, I would say that they're quite rare, and a metabolic disorder would probably not present with that lightning-like foudroyant onset. It would probably be over a period of a few days. So it is in the differential, but is probably easier to distinguish. I mentioned varicella or chickenpox and influenza, as well as strep. And in fact, our first case series on abrupt onset OCD was called Pediatric Infection-Triggered Autoimmune Neuropsychiatric Disorders, and the children had viral triggers as well as strep. We at the NIMH focused on the group A strep in large part because we had a prototype in Sydenham, Chorea. And Sydenham, Chorea is the neurologic manifestation of acute rheumatic fever. Probably, yes, you're all too young to remember rheumatic fever, fortunately. It's pretty much disappeared in the United States, but at the NIH, we were trying to find a medical model for obsessive compulsive disorder, and reports from the 1700s had suggested that Sydenham's might be a good choice. In this little 5-year-old, at first glance, she just kind of looks like the normal fidgety child. But if you look at her closely, every time she nods her head in response to a question or she tries to shift her posture, it sets off a cascade of involuntary movements, and her arms wiggle. She even sits on her hands to try and hold them still. When I was first examining these patients, I'd get fooled all the time because they'd be sitting on their hands and they'd have their legs wrapped around the legs of the chair, and all you'd see was this facial grimace, which I thought was just smiling for no good reason. No, that was a facial grimace. Here she's showing us what we call the pathognomonic, or the telltale sign of Sydenham chorea, the milkmaid's grip. And she grabs the examiner's finger and lets go, grabs, lets go. And it's because they have a failure to establish and maintain tetanic contractions. If you hold their hand as you're walking through a park, it literally feels like they're milking a cow. Here she shows you a bit of a failure to protrude her tongue, but more impressive is her failure to keep her eyes shut. She was asked to stick out your tongue and keep her eyes shut. She scrunches them up trying to keep them down, and she just can't. Failure to sustain tetanic contractions. On this right panel, we have a 12-year-old who came to us from Los Angeles, and she had a version of Sydenham that's called chorea mole, or truncal instability, truncal weakness. And in her case, the weakness and the loss of muscle tone was even more prominent than her choreoathetoid writhing movements. But if you'll notice, every step she takes, her toes curl up, her arms flail about like she's a puppet on a string. And again, she had to be pulled up out of the chair and supported as she walked. We spent the 2 weeks she was with us at the NIMH arranging for belts and wheelchairs and all kinds of things. And I can't actually remember if I put in the slide that would show her after plasmapheresis. I hope I did. If I didn't, I'll pull it up out of my queue, because by the end of treatment, she not only got up and walked, but we had her barefoot again. Her toes were nice and flat and still. And it's a difference if you do the videos on fast forward. They literally are just moving all the time, versus a typical child of that age is able to just walk with minimal extra movements. Well, rheumatic fever, acute rheumatic fever, or rheumatic heart disease, the pathophysiology, the mechanism, the cause, the disease mechanism has been suspected for 75 years to be the result of certain strains of group A strep, and not all of them. So I get asked all the time, well, kids get strep, on average 2 times during the school year. Why do some kids get PANDAS and the rest of the kids don't? One answer is it's strain specific. So we had a very bad strain go through the Washington, D.C. metro area about 6 years ago now. Increase in rheumatic heart disease, Sydenham, Chorea, and there was one classroom where 5 children ended up having PANDAS within just a very short period of time from each other. Turned out their teacher was a carrier of a particular strain of strep that was rheumatogenic as well as PANDASgenic. And there's also host susceptibility. So in the 1990s, we actually had a marker. It was called D817 that recognized first-degree relatives as well as patients with rheumatic fever. We snuck some PANDAS blood samples into the analyses being done at the Rockefeller University, and lo and behold, they also stained positive for the D817. Now, more recently, Dr. Jenny Frankovic and her team at Stanford University are using modern genetic sequencing and candidate gene approaches, and they're trying to replicate their findings from their Stanford cohort with our NIMH samples. If they do, we'll actually be able to declare a specific HLA, human leukocyte antigen, basically the backbone of the individualization of the immune system, that is very closely linked to ankylosing spondylitis, a kind of rheumatoid arthritis. So genetic marker on the horizon. I pray every day that it's going to pan out to be true. Certain strains of strep in those vulnerable children would be more problematic than in every other child in that classroom. Now, how does the strep do this? It does it by a process that's called molecular mimicry. And hopefully I saw enough of you raise your hands that you're in elementary schools. You'll forgive me the analogy to Harry Potter and Hermione under the invisibility cloak. Okay, I show my nerddom and that of my 3 daughters because we are going to see Harry Potter in New York at the end of the month. So I digress. That invisibility cloak, you know how in the movies it always had to be up on the edge so you knew where they were? Well, it's kind of the same with the strep. The strep hides from the immune system by putting antigens, proteins, glycoproteins, lipoproteins on its cell wall that look like its human host. And it's really good at that. In fact, it's so good that it's never had to adopt the genetic architecture to allow it to accept viral particles that can make it resistant to antibiotics. And that's why penicillin still can treat a strep infection. Every other bug worth its salt has been resistant to penicillin for decades, but not strep. It's very good for treatment. It's not so good for the immune system because just as we could see underneath the invisibility cloak, the immune system also detects this is a foreign protein that needs to be an inflammatory response mounted against it, an immune response. The problem is those antibodies that are very close, almost identical, but not quite, evoke such a strong immune response that the body goes against itself. And we have what we call misdirected autoimmunity, or a temporary loss of tolerance, we hope. That was the original theory. We actually now know that T cells become involved, probably even the innate immune system is involved, and so it is more complex, but the early hypothesis still works because that misdirected immune response, the symptom presentation totally depends on what the strain of the strep was. And if it's rheumatic heart disease, it looks like it's tubulin and some of the things that Dr. Madeline Cunningham has worked on, and you'll hear more about that later. If it's polyarthritis, you have polyarthritis that's associated with rheumatic fever, but you also have post-strep arthritis that comes in just one joint. The differences are very minimal, and yet one is included with rheumatic fever and the other isn't. Erythema marginatum and subcutaneous nodules are both skin manifestation of rheumatic fever. And finally, the one that was of interest to us, Sydenham, Chorea. So why was Sydenham chosen as a medical model for obsessive compulsive disorder in tics? Frankly, it was because from its very earliest presentations, described by Sir William Osler, who named it Sydenham because he was British and Sydenham was British. It should have actually been called de Bayeux's disease, but de Bayeux was a Frenchman, and he was not the one Osler gave the name. So he gave it to an Englishman instead of a Frenchman, and what they described was this abnormal St. Vitus's dance where the child looked like our Chorea mole, just a puppet on a string with every voluntary movement setting off a cascade of involuntary movements. And from the very earliest reports in the 1800s, a perseverativeness of behavior in the choreatic children. That perseverativeness of behavior, when you read the actual case reports, was very clearly compulsive rituals where the child had to do the same thing, washing their hands, checking, asking questions over and over and over again. Ebaugh and Hamness in 1922 and 1926 wrote these lovely case descriptions. I'm going to share a couple with those with you in a moment. Chapman, Freeman, and Grimshaw in the 1950s and 60s actually went into psychiatric hospitals and compared rates of childhood history of Sydenham chorea among patients with obsessive compulsive neurosis, the name at the time, versus psychotic disorders. And those who had obsessive compulsive neurosis were much more likely to have had rheumatic fever as children. We did one retrospective study of about 60 patients in which the children who had Sydenham chorea had obsessive compulsive symptoms about 2/3 of the time. Those who had rheumatic heart disease only without any chorea had 0%. So it was very unique to something associated with the involvement of the basal ganglia of the brain. And very importantly for our model, 2 to 4 weeks before the onset of the chorea is when the OCD started. So if you think about it sort of on a scientific level, it could have been a dose-response effect where just a larger hit by that strep may have provoked the full-blown syndrome of Sydenham chorea, and a lighter dose or maybe a less impactful genetic makeup could have led to just the OCD and the other symptoms we're going to talk about in a minute. But what we do know is that from prospective studies done down in Brazil, that if you have recurrent episodes, it's not a good thing. So that at initial presentation, 2/3 of the patients had obsessive compulsive symptoms, again, starting 2 to 4 weeks before the chorea began, peaking as the chorea did, and then actually lingering longer than those abnormal movements. But by the time that child had had 3 recurrences, it was 100% of the children had OCD, and it was non-responsive to medications and traditional therapies. Well, that's what's been driving us to try and figure out this mechanism, and also what's pushed us, frankly, to move, as has the autoimmune encephalitis community, to taking the weight of clinical consensus to define treatment guidelines that include immunomodulatory treatments with only a limited number of controlled trials. We're going to talk in a minute about the controversy, and I'll show you the paper, but I think that the thing that, again, you need to take away is just that one point, hammer, hammer, hammer. If a child has acute behavioral disruptions, look for strep, look for other infections. What else are we going to look for? The typical psychosocial stressors that could lead you to have an abrupt onset of anxiety and the other symptomatology. Treat strep if you find it. Interestingly, despite the fact that all of the criticism has come from the pediatric neurology community, they are ignoring their own literature, which started in the 1900s, documenting post-infectious onset of severe tic disorders, very comparable to what we initially described in the PANDAS cohort. In those drug trials that I talked about, the children who 1/4 to 1/3 who had an abrupt onset of symptoms also had the presence of choreiform movements. And choreiform movements were described by Towen in 1984 as fine piano-playing movements just of the fingers, complete stability of the arms, the shoulders. And if you think about our 5-year-old sitting there in the chair, when she was asked to put her hands up like this, or the Chorea mole, you ask her to put her hands up, they fall. So if a child can do this, that's choreiform. Unfortunately, the names sound the same. They're not the same. And they are not missed Sydenham chorea, most importantly. All right, so collapse 2 decades of discovery into 2 slides. And it all is based on what I've already shared with you, those parallel investigations of children with Sydenham chorea and children with non-selected obsessive compulsive disorder that just kept coming back over and over and again, including neuroanatomic reports of abnormalities in the basal ganglia and Sydenham chorea, and everything from PET studies to MRIs to neuropsychological testing, revealing that in childhood onset obsessive compulsive disorder, the dysfunction also lay in the basal ganglia, specific in the caudate nucleus. This is important because adult OCD, which starts primarily during adolescence and has a 2 female to 1 male ratio, as opposed to childhood, which is almost 3 boys to 1 girl, at adolescence, they don't have a triad of OCD, tics, and ADHD. They have a triad of OCD, depression, and generalized anxiety. And so if you're getting that frontal lobe kind of worried presentation, I wouldn't even think about PANDAS as a possibility because it is orbital frontal cortex. It's not in the caudate, in the putamen. So in 1998, we proposed strep as an association, a temporal association. We've come on in the last 20 years with sufficient evidence to now feel that there's an etiologic relationship, that actually strep is the causative organism for some patients with abrupt onset OCD that we have defined by the PANDAS criteria. That's on the basis of 5 lines of evidence, everything from epidemiologic studies, including one that was just done in Denmark last year, over 1 million children, in which they found a 3-fold increase in diagnosis of obsessive compulsive disorder and tic disorders among children who had had a strep infection versus those who were strep-free. Also increased risk among their siblings, and those children who had had recurrent streps had the highest frequency at almost a 10-fold increase. Gorgeous data, suggestive, but not proof of a causal relationship. Better data came out of the Florida study where Tanya Murphy went into a school system, evaluated almost 700 children every month as they stood in line to get throat cultures. And what she found was the presence of those choreiform movements and impulsive ADHD-like behaviors in the children predicted a positive throat culture. And as the children had more than one, if they had 2 or 3 strep during the year, their chances of having the problematic behaviors increased. Picacchiero and Marie Murphy, not Tanya Murphy, up in New York, back in 2002, reported a group of 12 children who half of them presented initially with symptoms of a urinary tract infection, urinary frequency, urgency, and a new onset of bedwetting. The urinalysis was clear, the culture was negative, and they very wisely did a throat culture, was positive. They treated them, and 8 of the 12 children who had positive throat cultures and behavioral abnormalities resolved just with antibiotics alone. We've demonstrated in 2 different studies that if you can adequately prevent the infections, you can mitigate the neuropsychiatric symptom exacerbations, including a study where we compared the effectiveness of azithromycin and penicillin, did a year of observations in the cohort of 22 children, and documented that when we eradicated strep, we also decreased the number of neuropsychiatric exacerbations from an average of 2.2 per child down to 0.7. We're going to talk more later about these cross-reactive antibodies because they were the thing that sort of led to 5 animal models in which serum from our children is variously infused either into the brain or in a sensitized mouse infused and then passively transferred to another mouse who exhibits behavioral abnormalities of hyperactivity, repetitive behaviors, and has gross pathology with abnormalities of the basal ganglia, or in an animal striatum. Those animal models have been followed recently by another one in which recurrent strep infections of the nasal-associated lymphoid tissue, the NALT, which is the mouse equivalent of our adenoids. So it lays right at the cribriform plate, and the cribriform plate allows things to move across the brain. But what Dr. Agaliu, Clary, and others documented was that after the fourth strep infection, T cells were actually produced that were strep specific and could carry an inflammatory response into the brain, where it became self-perpetuating. Well, that's 6 animal models from 5 different groups, all of which support the role, an etiologic role for strep. Despite that, and many, many other papers, this decade of discovery was followed by now 2.5 decades of controversy, with just a series of editorials, primarily in the neurology literature, originally questioning the hypothesis that strep could cause OCD and tics. And when we pulled the Sydenham's literature, they had to retract that. And then they began to question the existence of the PANDAS and eventually said, it's been the topic of intense debate and controversy. And I'm thinking about sort of Washington right now, right? There's nothing that can stop progress better than labeling it controversial. And to label it controversial, all you have to do is say it's controversial and repeat it enough times, and suddenly it is. That's my version of this. I think if you talk to Singer, Gilbert, Mink, and Curlin, they might have a different view of the debate. But what I can tell you is that Harvey Singer, in particular, who's at Johns Hopkins, has written papers supportive of PANDAS with us using our kid serum, and written negative papers claiming that it can't exist using serum from Curlin's kids. Well, the controversy continues, and in fact, if anything, I think it's gotten worse because pediatricians are now in the middle of the crossfire just as our families are. And I honestly, if I were in private practice, I have no idea how I would be reading the literature right now. Because Journal of Pediatrics is probably the most respected sort of medical science journal in peds, and it published this commentary, which was a review article responding to the publication by my consortium of treatment guidelines, in which they say, nevertheless, there remains a pressing need to better define, we agree, the clinical manifestations, laboratory and neuroimaging findings, therapeutic responses, and clinical course. They should reduce or eliminate reliance on reports of parents and use blinded researchers, I don't know for what. Parents and the children are the only ones who know what life is like at home, but I guess we could do videos. And they don't believe there's a prominent role in inflammation, and most problematic is their recommendation, if it's a psychiatric-only presentation, that you should just send it to a psychiatrist for SSRIs and CBT and ignore the possibility this might be brain-based. The consortium's been working for months since this paper came out in May to try and word tactfully and appropriately a response to this. But the bottom line is the psychiatrists are like, what are they talking about? Don't they know that anti-NMDA receptor encephalitis has a psychiatric-only presentation over 50% of the time? And if you wait for seizures, that child is actually getting close to the point where you're not going to be able to rescue them. So the AE community, led by Joseph Dalmo, has had no controversy over their recommendations to initiate IVIG and plasmapheresis as early in the diagnosis as it's suspected, in order to try and effect a better outcome. And as they wrote, despite the complete lack of controlled trials. In contrast, we do have controlled trials, and I see enough heads nodding that I am not going to play this video because it makes me cringe every time I hear it. This is a 10-year-old girl who by now has seen 11 doctors who refused to treat her for PANDAS, half of them because it was controversial, the other half because they knew it didn't exist. Meantime, she is getting worse and worse, and she's in the emergency room begging the doctors to kill her. You have to have something to kill me now, because she was A, suicidal, B, so completely miserable, life was not worth living, and I think she was 8. I said she was 10, but she was only 8. It's very, very scary, and sad. Despite that, I actually understand where the controversy started, and we have been as skeptical of this entire thing as any of the critics have been, because it's made just on a clinical and behavioral basis. However, the most recent accusations have become ludicrous. They tell us that we just missed Sydenham, Chorea. Well, the Neurologic Institute actually devoted a large portion of their movement disorder clinic to help us study those early children with Sydenham, Chorea, and PANDAS. 3 different neurologists would see those patients, and each time they concluded there was absolutely no evidence for Chorea there. And the question about the etiologic role for strep. Certainly the frequency of group A strep. 2/3 to 3/4 of kids will have a strep every school year, and it is a fact that there is a carrier status. However, the true rate of strep carriers is less than 5%. Otherwise, it would just be so ubiquitous you would never be able to eradicate it, because a carrier is defined by a child who has the strep in their throat and never mounts an immune response to it. And when you use the Pfizer Labs panel of 13 different antibodies that recognize multiple antigens on that strep, you find out that many children actually have something other than a rise in ASO and anti-DNase B. I think that the main feature then that we're going to really emphasize going forward in the PANDAS diagnosis is not the fact that they have OCD or tics. Tics are now out of the equation, and out of respect to the neurologists who claim that they cannot tell the difference in the clinic between an abrupt onset and the acute onset, because every tic is abrupt in onset. It wasn't there yesterday and it's here today. Well, we're not talking about a child who didn't have an eye blink tic yesterday and has one today. We're talking about a child who suddenly has eye blinking, shoulder shrugging, and multiple vocalizations in association with OCD, with separation anxiety, with a new onset of insomnia, going from a child who could fall asleep in 15, 20 minutes when you put him to bed at 8 o'clock to one who's still up at 1 or 2 in the morning and is miserable that entire time so that the parent has to lie with them. Poor concentration, impulsivity, aggressiveness. Parents have very often told me they felt their child was possessed, and that they had just changed so dramatically from sort of the model student and a child, anyone be proud to have anywhere, to a child who was not only miserable, but making everybody in the family miserable as well. Eating disorders are a particularly dangerous symptom because the child can actually refuse to eat or drink anything. They won't swallow their own saliva, and because it might be contaminated. So they're spitting, they're becoming dehydrated, they have to be admitted for fluid rehydration as well as tube feedings. And in those early reports from the 1920s, the 2 children that I pointed out as examples, both of them were on tube feedings because of contamination concerns. Hallucinations happen in 10% of the patients, and in the 1960s, Nancy Wertheimer described rheumatic schizophrenia. I think that is very real, and they get all kinds of visual, auditory, and even olfactory hallucinations. Miro Kovacevic from Illinois, from Hinsdale, described the terror-stricken or hypervigilant appearance, and it makes great sense. They have an increase in sympathetic tone. They have that hyper-alert, hyper-aroused, hypervigilant stance of a patient in their fight or flight response. And the fight or flight can also explain a lot of the irritability and the aggression, although it can also happen without any kind of provocation. I needed to stop anyway before I tried to talk to you about urinary frequency, urgency, and new onset of daytime accidents and nighttime bedwetting, because this is probably the pathognomonic sign of PANDAS. Pathognomonic just means telltale, like that milkmaid's grip of Sydenham, Chorea. Same thing for us is when a child has multiple behavioral symptoms and at the same time starts wetting the bed again. They're 10 years old. They've been dry since they were 3. Now they're having daytime accidents. If they're 10 years old, they're going to hide it from you, but moms will see that there's urine stains in the underwear from the daytime. We think that that's actually because the internal sphincter and the external sphincter of the urethra is under differential nervous control, and that what they've done is lose control of the internal autonomic sphincter, and all urinary continence is being maintained with the external. That's why a little boy told us that he was so, he would just scream in frustration because he would void, he'd get to the bathroom door and feel like he had to void again, like there was a drop of urine that he needed to pee out. So multiple times to the trips to the bathroom in an hour, not just multiple times in a day. Handwriting changes, I'll show you in a minute. Tics, about 70% of the patients will have them, and they're very useful because then it's a neurologic sign, and you can actually even meet Gilbert and Singer's definition of something to be concerned about. But they also have cognitive changes. The children often will have amnesia for the entire event. And when we presented these symptoms at a meeting in the UK a few weeks ago, one of the adult psychiatrists in the audience said, half of the symptoms that you have up there describe delirium, and you need to focus on that as your presenting symptom. So somebody was telling me that they really, oh, I know who it was Natalie. So where are you, Natalie? There you are. Thank you for that, because I'm going to remember it, and I'll try to remember to credit you every time. Natalie talked about how when you refer these patients or you're trying to get some help for these kids, talk about the changes in the mental status exam, talk about the change in consciousness levels, talk about that insomnia, certainly talk about the urinary symptoms, kind of don't even talk about the OCD and the aggression. And sensory hypersensitivity or insensitivity, they look incredibly encephalopathic. We've had children with both Sydenhams and PANDAS who need to have all the room lights off, are wearing earphones to block out noises. They look just like our poor children with autism who are in that hypersensory state. So we took all those comorbid symptoms, and that actually became the defining criteria for PANS, Pediatric Acute Onset Neuropsychiatric Syndrome. In the spirit of moving on to some clinically useful information, we won't talk about the controversy, but it's only about the name. There's absolutely no disagreement in what PANS and CANS look like. It's only what you call it. So if you leave off the P or the C and just call it Acute Onset Neuropsychiatric Syndrome, we'll be fine. What you have is just an abrupt onset lightning-like strike. That's what foudroyant means. It's lightning-like abruptness of onset of OCD, eating restrictions, fluid intake restrictions, plus at least 2 of 7. And we're going to rearrange these because we know now that you have emotional, cognitive, behavioral, neurologic, and somatic symptomatology, and that you almost always have 3 of those 5 categories involved. We talked again about how probably the pathognomonic signs and symptoms are going to be the sleep disturbances and the enuresis or urinary frequency. It occurs in anywhere between 80 and 98% of the patients. So it's definitely common enough that if that was a requirement for all your cases, you're fine. You're only going to be missing a few kids who may or may not fit the criteria. Behavioral regression can be extreme. I need some audience participation. How old is this child who drew that picture? Oh, come on, some of you already know the answer. You said 10. That's not fair. Thank you, 4 or 5. That's what the picture looked like. They were cheating because they knew the second panel showed that the picture had actually been drawn by a 10-year-old girl who was actually a patient of Dr. K's. And this was in June, and this is in September following successful treatment with IVIG. Margin drift. I love the teacher comments because a mom came up to me in Germany and showed me her child's paper journal with the teacher comments in German, the child writing in German, but it said exactly the same thing. How about starting your sentences at the red margin? That actually may be a sign of left-sided neglect, and a way to look at that in better and more acceptable ways is if you see that kind of margin drift on a client or a patient, then what you want to do is administer a clock test and see if they squish all of the numbers of the clock over onto the right side. Dysgraphia, we don't know for sure that it couldn't be caused by those choreiform movements, but they can do other fine motor tasks without difficulty, so we think it's actually probably central. And it goes along with deficits of executive functions, specifically deficits that require simultaneous excitation and inhibition, which is the more sophisticated function within the caudate nucleus, and is shown here in these results. Children with PANDAS had a pattern very similar to that of Sydenham chorea, although less severe. And again, we talked about maybe a dose response, and we've even toyed with the idea that maybe PANDAS is a form fruste of Sydenham chorea. It's very different from children who have non-PANDAS Tourette syndrome. And if I showed you the results for non-PANDAS OCD, they would be even less like this pattern, because in non-PANDAS OCD, they don't have abnormalities on any of these, but in Tourette's and ADHD, the primary deficit actually lies in the response execution, or you guys all know it as the go, no-go task, where they have to button press when they see a certain color X and not when they see other colors. The ray asterisk gets at visual spatial skills and higher levels of executive functioning. This is a figure from one of Tanya Murphy's patients down at University of South Florida in Tampa, St. Pete. What she found is that more than 80% of her patients scored below the first percentile for their age on the copy task. And if you know the ray asterisk, it's actually a test of working memory, and the real test is to reproduce the figure 5 minutes later. They did that pretty well. Their 5-minute scores were more in the median than the copy, in which they're just sitting there with a piece of paper and asked to recreate this picture on this piece of paper. And they missed the sort of telltale cross here, they missed the diagonal lines, and if you asked them to close their eyes and then not have it next to them, they would actually do better. My adult patients that I interviewed for a PET study that we were doing had very similar deficits when they had an early childhood onset. And what they complained about was not being able to read maps. Fortunately for them, we now have Google Maps, and nobody needs to read a map. And they were unable to sort of orient in three-dimensional space. So they would get lost going through a building like this one where you said, to go to the bathroom, you need to turn right, right again. And when you see this on the left, then you're going to turn there to the right. Electroencephalography demonstrates some softer signs of encephalopathic process, specifically epileptiform discharges and diffuse or focal slowing, in a total of about 17% of the patients. And those abnormal EEG findings, both the type and the frequency, were identical in our cohort of children with Sydenham, Chorea. More recently, we've come to depend on polysomnography, and not just the sort of send the child for a sleep study to see if they have apnea because they have big tonsils or adenoids and they're snoring so loudly, but actually a neurologic assessment that looks at movement during REM sleep. And what we find is that in this cohort of 12 children, and we've now replicated it in another group of kids, during acute illness, they have evidence of REM behavior disorder where they fail to establish atony. They are not paralyzed during REM sleep. And normally during REM, the only thing moving is your eyes, rapid eye movement sleep. They've conjectured that the eyes are following the dreams. I'm not sure that that's true, but what is known to be true is that you can't move during REM sleep unless you have REM behavior disorder. And these, if they didn't meet full criteria for RBD, then they actually continued to move and to moan and to make motions and noises during REM sleep. Both of those have been reported in patients with Parkinson's disease, which is destruction of the basal ganglia, to have a poor prognostic sign. So far, our data look like it's not poor prognostic sign in our children with PANDAS, as it appears to improve during convalescent period. And this may end up, like that urinary frequency, being a really useful clinical test. In the meantime, if you can get a PSG with a neurologic read, it's a wonderful thing to do because there's absolutely nothing else that's going to produce this on the sleep study. Well, all of this is written up in excruciating detail in the Journal of Child and Adolescent Psychopharmacology. This was the online publication date. You can actually get it through the PANDAS Network, PANDAS Physicians Network, or even through PubMed in January 2015 in JCAP. What it basically says is what I've already told you. Do a comprehensive workup, including a family history. Look for occult infections, especially pediatricians. Examine the rectal area. Make sure they don't have perianal strep. That can be an occult cause of ongoing antigenic source. Look for the choreiform movements, dilated pupils, that hyper-alert, hyper-vigilant appearance. Rule out Sydenham chorea, and rule out other forms of autoimmune encephalitis, which you can only do by obtaining a lumbar puncture. You have to get an LP as well as blood. We know that from anti-NMDA and from all the other autoimmune encephalitis. And what those have shown us is that the blood could be positive and the CSF negative, in which case it's probably not a problem. And conversely, the CSF can be positive when the serum is negative. Ideally, you'll have both positive, and sometimes you have only the serum. If you also have the clinical picture, then that would be sufficient. Okay, are you going to do a lumbar puncture on the child who's still getting to school and is only having an hour or so of symptoms a day? Probably not. And those are described in the treatment algorithms as the mild cases in which you're going to start possibly just with antibiotics or just with nonsteroidal anti-inflammatories. But if you're considering IVIG, even steroids, I believe personally that you need to have an LP on that child to make sure that it's not symptoms of something, possibly even an infectious encephalitis that would be made worse with your treatments. EEG polysomnography can help you to make that diagnosis. Swallowing study is on here because in our Sydenham Chorea patients, we actually had a number of them who developed what we called an obsessional fear of choking, and that was because Sydenham's, you saw the jerky movements. Well, when you swallow, you have involuntary muscles and voluntary muscles, and those two have to be just doing this very carefully orchestrated dance. If they're not, you actually can't swallow properly. So a swallowing study is a rule out to make sure you haven't missed an occult Sydenham. Throat culture is really the only thing I do to try and decide if this child has strep as a trigger. It's most likely that it's going to come in the medical records of that child's siblings, and that the sibling had a strep throat infection about a month ago or 2 weeks ago. This child is asymptomatic for any symptoms of pharyngitis. Again, this has caused controversy, but it shouldn't, because all of the literature from the 1950s documented that the patients who developed acute rheumatic heart disease were those in whom they had a relatively asymptomatic pharyngitis. Just a little tickle, a little bit of a sore throat, but they also had a runny nose. Well, if you have any kind of rhinitis, in pediatrics, we're taught don't do a throat culture. In this particular group of patients, do it and treat if it's positive. I personally don't bother with anti-streptococcal antibody titers because they tend to be high in grade school age children just because they've been exposed to strep. They can go up and stay up for a really, really long time. And frankly, too many families get really number conscious, and they're writing to me and saying, oh, last month it was 600 and this month it's 660. That's called lab variability, people, and it's meaningless. On the other hand, anti-nuclear antibody titers, which we always sort of poo-poo, is this non-specific, always positive in everything that's inflammatory. Well, in this disease, that's helpful. Almost 60% of our patients were positive for ANA during the acute phase of illness. We used to actually celebrate when a child was in our IVIG trial and had a positive ANA because it tended to be those children did better. And in fact, that trend was statistically almost significant when we looked at it at the reporting of that paper. You're going to hear more about moleculara from Dr. Shimasaki, so I'm not even going to try to talk about that today. But we will just focus for one more minute on some of the other evidence that there's autoimmunity at work here. And you've heard about Charlie's Law, but that will get you one course of IVIG. It may not get you more than one course of IVIG, and some of the children actually need more. So it's really important to do an adequate immune workup on these patients. One of the leading causes of autoimmunity, particularly in children, is an early immunodeficiency. And a lot of our children have low IgG levels, they might have low IgA. And so if you find an immunodeficiency, particularly if they have low IgG, that can be the basis on which you recommend treatment with intravenous immunoglobulin. We've just started at the NIMH a multi-site characterization study of PANDAS. We currently have 8 participating sites. I'm hoping that all 14 of the sites within our consortium will be able to come on board soon, because that's one of the questions we want to ask is what baseline labs are most helpful, which ones are predicting a treatment response, how can we identify these children when they first present to the clinic. So have me back in a year or two, and I hope to be able to give you the answer on that. Good evidence of basal ganglia involvement, enlargement of the caudate, putamen, and globus pallidus on MRI scan as a research group, not individually, except for one patient who had the amazing shrinking caudate. Here at baseline, his caudate is more than 20% enlarged for his age, sex, and weight. He also was spending 98% of his waking hours doing compulsions in response to obsessional fears that the two sides of his body weren't exactly the same, as well as concerns that some harm was going to come to his parents. Fortunately, he responded to plasmapheresis and had a complete eradication of his symptoms, and following treatment, his caudate size had normalized. Harry Shigani used a ligand, a marker that recognizes activated microglia, a sign of inflammation within the brain, and what he found was the patients with PANDAS had increased activity or increased presence of these activated microglia within the caudate and putamen during acute illness, and following successful treatment with IVIG, the hyperactivity was absent and the scan had normalized. Interestingly, and much to the dismay of the neurologists who hate PANDAS, he also found increased activity in the lentiform nucleus of children with non-PANDAS Tourette's. So it appears that perhaps inflammation may play a role in more Tourette's than had been previously recognized. But as I said, we're not talking about tics anymore. We're trying to focus on those behaviors that are hurting children and causing them to not be able to get to school and to live their life. Well, the cross-reactive antibodies I like because it's such a clean, neat story. We were able to completely blind the samples, so our longtime collaborator, Madeline Cunningham at the University of Oklahoma, is been funded by the Heart Institute for almost 30 years to do research on rheumatic heart disease. And she was looking for us to give her samples from our Sydenham, Chorea patients who also had rheumatic heart disease. I threw in a few of our PANDAS kids, and lo and behold, they had exactly the same kind of staining. And very importantly, the children who had regular, what we call garden variety, but non-acute onset of Tourette's and OCD looked exactly like the healthy volunteers in those studies, whereas the staining of the children with PANDAS and Sydenham, Chorea was virtually indistinguishable. So very clear reactivity of the neurons with basal ganglia structures, specifically the caudate and putamen. Importantly, these antibodies were present in higher titers during acute illness than during convalescence. And here are just 3 subjects in which we see that's true. And more recently, we know that it isn't just the antibodies that, the antigens that Dr. Cunningham has been using, but that it may be more diffuse, as work at Yale University has revealed that patients with Sydenham, PANDAS, have antibodies in their serum that recognize cholinergic interneurons in the striatum, in the basal ganglia. Those cholinergic neurons actually literally are sort of the scaffolding that holds all of the dopaminergic, norepinergic, serotonergic, all those various neurochemicals that are so complex. These cholinergic neurons are intimately involved with that. They also happen to be involved with REM behavior disorder. So the story's coming together in such a beautiful way that, again, I'm making promises that I hope to be able to keep. Then a year or two, we will not only have sort of the definitive diagnostic test rather than a very good current test in the Cunningham panel, but we'll also have a much better idea about how we can be better treating these children with psychopharmacologic drugs. Because the SSRIs can offer a little bit of help with the obsessional symptoms, but they don't touch the rest of it. We also know that these antibodies have bioactivity, and this is a slide from Dr. Cunningham showing that the autoantibody appears to attach to those dopaminergic neurons, dopamine D1 and D2 receptors, and causes dopamine release, which could give rise to unwanted movement, but the imbalance between serotonin and dopamine is responsible for the obsessive compulsive symptoms and the anxiety symptoms. That cell signaling is indicated by CaMKII 2 activation, and I just realized I don't even have my numbers here on the left side, so I'll leave you to hear about that from Dr. Shimasaki. But here's a different example. If instead of binding here, that it's actually binding directly to the dopamine receptors. And if you have an antibody that can bind to the receptor and induce signaling, then you actually have a bioactive antibody itself. Transfer of the antibodies I've already shared with you can provoke these symptoms, but probably the most exciting development in the last 30 years is not even the antibody story. It's work from Agaliu and Cleary, and now Dratan is up at Columbia University documenting that it isn't just the humoral system or the humoral immune system antibodies, but it's also the cellular immune system through Th17 cells. And what he's shown is that 4 consecutive infections with group A strep in mice prompt the production of these Th17 cells that traffic along the olfactory nerve directly into the base of the brain. Well, clinically and personally as a pediatrician, I was most excited by the fact that we could make a difference in these children's state of disease by using immunomodulatory treatment trials. And this study has been criticized actually since it was first published in The Lancet, one of the leading journals of medicine in the world, because we didn't have a control for plasma exchange. I actually designed, after this study, a sham apheresis study, and we put 3 patients into it before I abandoned it. Because can you imagine putting a central line in a child's neck, putting them in the hospital for 2 weeks, and all you're doing is hooking them up to the machine and faking an apheresis procedure? No, that's not ethical. It was not stomachable, if that's a word. So this is the best we're going to ever do. And what it very clearly showed, the randomization was done by the NIH pharmacy, not by us. Plasma exchange is 5 single volume exchanges over a 2-week period, which removes 90% of circulating antibodies. But it actually also has profound impact on both the innate and the humoral immune response, an adaptive immune response. So it may have been resetting of the cytokines, it may have been many other things. Similarly, IVIG is a very broad spectrum drug, and it's sort of like using a sledgehammer when you'd really like to have a very fine artist chisel. 9 children randomized to 1 gram per kilogram of each 2 consecutive days of infusions of intravenous immunoglobulin, and 10 children randomized to receive saline in exactly the same fashion. All the children were pre-medicated with Benadryl, with Tylenol. They were kept in bed for 2 days for the infusions, and at the end of that hospitalization for those infusions, 9 of the 10 children who received placebo thought that they got active drug. That is incredibly important because when they came back a month later, there had been 0 improvement in the placebo group. In contrast, there was a 45% reduction in symptoms in the IVIG group, including several children who got down into the subclinical or completely remitted range. And in the plasmapheresis group, it was so amazing, frankly, that we didn't quite believe it until we saw that young boy with the change in his caudate size and the fact that all of these children maintained their treatment gains for a full year because they had a 65% reduction in symptom severity over the course of a month. They also had improvement in their handwriting, another picture loaned to us by Dr. Kovacevic. However, in the interest of full disclosure, and more importantly, because I want to remind you that that IVIG is not a panacea, it is not the fix-all for these children. Our most recent trial that we did in conjunction with Yale University failed to find a significant difference between IVIG here, which definitely had more improvement than the placebo did, but the standard deviation in response was so high that we really didn't see a difference. In part, it was because the 2 kids that Paul and I weren't sure we wanted in. They both had a really good response to antibiotics, and they were on a downhill trajectory. In retrospect, we should have just waited to see if they met randomization criteria a couple of weeks later, because they had a great response to placebo. And in contrast, the children on IVIG, the parents were terrified that they had gotten the placebo, and so they underreported significantly in the structured ratings with Yale how much improvement the children had had. That sounds like a lot of explaining away, and if you read the paper, we did none of that explaining away because the reality was there was no superiority of IVIG for placebo. However, in the open label phase, with 25 of the 35 children getting open label IVIG, the reduction in symptom severity was identical to that in the first control trial at the NIMH. Now, I'm going to just, hopefully, can I play this? No, I have only 2 minutes.
The day before that night, I was perfectly fine. I went to swim practice for 2 hours. I did my whole normal day, and the next day because I was already on antibiotics, so I went back to doing stuff, and the next day I just wasn't regular.
Yeah, yeah. And how long ago was that? Can you remind me? How was that? Just
When was that? Well,
It was the end of April.
yeah, it's the end of April.
Okay, I'm going to stop it there and just share with you that at that rating, he was already severely ill. He was homebound. He couldn't leave the house, both for separation fears and also contamination fears. His mother was literally washing the floor with bleach in order to have him walk from his bedroom to the table to eat. She had to bleach it down in his presence before he could eat because 2 of his brothers were sources of contamination for him. My staff tried to give him a 40 out of 40, and I said, no, he could get worse. And they said, no, that's not possible. He couldn't possibly get worse. But fortunately, I prevailed, and they gave him a 36 out of 40 on the Yale-Brown obsessive-compulsive symptom severity, which basically meant he was having nearly constant obsessional thoughts with great distress, great interference. Well, he received placebo in the blinded phase, and 6 weeks later, he was much worse. He couldn't get out of his bed now because of contaminants and was literally just cowering in the corner, completely depressed, crying, and quite upset because when he had tried to leave the house, somebody had mentioned basketball, which was another source of contamination. He received open-label IVIG, and again, in the interest of time, I won't play this, but what he and his mother end up fighting about is whether he's 90% better or 95. But it's so wonderful to see this. At 3 days, he was able to leave the house, and he dunked a basketball, which previously he wouldn't even touch one. 4 days, he put away his hand sanitizer. At 2 weeks, he felt most of his contamination fears were gone, and at 3 weeks, he could go back to swim practice. So at 1 month, we couldn't find any OCD on him, and that to me is an IVIG response. So anything short of that is frustrating for me, and we try to move ahead. That kind of experience, as well as 2 controlled trials and now open label reports in dozens and dozens of patients, were the basis for the treatment recommendations in the Journal of Child and Adolescent Psychopharmacology, in which we recommend for mild to moderate cases that you start with nonsteroidal anti-inflammatories. The Stanford Clinic has shown that they can shorten the current episode and prolong the time towards relapse. IVIG for moderately severe children, and in almost all patients, a single course is enough, but Tanya Murphy has some anecdotal data showing that in teenagers or children who've had longer periods of illness, it may be response after the 3rd episode. And this should say therapeutic plasmapheresis. I thought I fixed all these mistakes. We reserve that for children who have severe symptoms such as Georgia, where they can't leave the house, they're just being tortured almost constantly with their obsessional fears. And certainly for children who have life-threatening symptoms, either impulsivity, where they're acting out on suicidal ideation, or those patients who can't eat and drink. If it is not PANDAS, please, please, please do not pursue immune therapies. They're not going to work, and they may be harmful to that child. So we actually did plasmapheresis on non-PANDAS OCD shortly after the success of that first study that was published in 1999. Open label, best possible sort of placebo effect that you could expect. 5 children with severe OCD, 0 improvement. Hoekstra in Denmark did the same thing using IVIG for non-PANDAS tic disorders, 0 improvement. So when families are pushing for a PANDAS diagnosis and you know in your heart that's not what the problem is, you can point them to this paper by Nicholson et al. Immune therapy is not going to help. I'm going to summarize by just saying if in a PANDAS patient, if you'll treat the source, treat the immune system dysfunction, and treat the symptoms, and don't forget any one of those. Think about this as pneumonia in an asthmatic child. You treat the pneumonia if it's bacterial with antibiotics to get rid of the source, the provocation of the immune stimulation. You treat with oral or inhaled steroids, as well as upping doses of other medications to try and get the asthmatic response under control. But many times, if that child's having coughing so severe that they're up all night, you may also use a cough suppressant, especially if you're old school and not new new AAP, or you might use honey and lemon, is what my daughter told me. I told her next time she had a really bad cough to use honey and lemon. But it's a 3-legged stool. Treatment and prevention of infections. We recommend in the treatment guidelines an initial course of a month of antibiotics. I was expecting most of the controversy to lie around this. The pediatric infectious disease community actually reviewed the recommendations and felt that they were entirely in line, and given the stakes, they thought that it was appropriate to try 3 to 4 weeks, particularly since Tanya Murphy did a lovely double-blind trial of azithromycin versus placebo and documented very clearly that you can produce symptomatic improvements just with azithromycin. The favorite drug is actually Augmentin, and we think it has nothing to do with the amoxicillin component of the Augmentin. It's actually the clavulanic acid, because clavulanic acid has very profound impact on the immune system, and particularly on the innate immune system. So Kyle Williams has just gotten clavulanic acid and is doing a controlled trial for that. Only if the child is clearly a PANDAS and has had 2 strep-triggered episodes, both of which were severe enough that you considered interventions should you consider long-term prophylaxis. If you start it, you have to be committed to it and you have to keep it up, because this is not something that you play around with, and we recommend using good old PenVK, or in Italy they're using IM penicillin. Very, very importantly, don't forget the symptomatic treatment. These children are going to have symptoms, so you have to use medications that we know can be helpful for OCD, for anxiety, for other symptoms. And cognitive behavior therapy is actually a wonderful, wonderful tool. In the POTS study, it was proven to be more effective than medications alone. The most effective treatment for childhood onset OCD was the combination of SSRIs and CBT. It's the same in our kids with PANS-PANDAS, whether they've got whether they have PANS-PANDAS OCD or not. And you're going to hear more about how to manage this in the school setting later, so I'm just going to recommend this resource to you by Patricia Duran, but there's also some more back on the table when we take our break. And I'll leave this slide up as I close and say thank you very much.